Well, I do appreciate the chance to talk, to speak about decision-making in pediatric palliative care. And I think intentionally this lecture is backed up after Barb's wonderful lecture last week. But as I've said in the past, I love that, but I really don't because that is such a good talk and she's such a good speaker and so educational that I don't love following that. But I do appreciate the chance to discuss how it's a little bit different and in pediatrics and bring up some of the issues and challenges that we face. Let me make there you go. No disclosures. And I usually start this with one of our patients. Those of you who heard this talk before, it's the same patient I've discussed in the past. This is a 16-year-old male with a long-standing history of a neurodegenerative condition that has gotten severely worse over the last few years. He now can't ambulate. He communicates only with thumbs up and thumbs down and is entirely dependent on G-tube feeds. The family has struggled to watch his decline over the past several years and feel they're torturing with ongoing interventions. This sounds actually quite familiar to a case I think our fellow presented not that long ago of a young adult with a very similar type situation. The issue in this case is he's admitted with worsening agitation and combative behavior, especially when his feeds are connected. And he himself has expressed in different ways over the years that he wants to go see grandpa in heaven. And the family is now asking about that. So they're asking about his tube feeds. And I realized when I talked to this audience, everyone who's listening is probably like, well, gee, that sounds horrible. Sounds like a terminal progressive condition. Of course, this doesn't have to be continued. But the challenge is he's 16 years old. So I use this case as sort of the backdrop of what do we do with that when he's 16? If he was 18 or 20, how does that change the conversation and maybe make it, maybe not simpler might be the wrong word, but certainly a little more straightforward potentially, as opposed to a 16-year-old. So my goal, get this to move, today is to describe some of the differences in decision-making in pediatric versus adult medicine on the heels of Barb's great talk last week, discuss some specific ethical challenges that we encounter in peds palliative care around these decisions in regards to children as opposed to adults, and then discuss a bit about advanced care planning in pediatrics. And spoiler alert, I don't have one single answer and it's not straightforward, but we'll get to that near the end. So I often start this with a little bit of a review of ethics, which all of us are well aware of. My comment about it is when you think about the basics of ethics, and I do realize that we do have a real pediatric bioethicist in our presence. So he can correct me if I'm wrong about these things and certainly would like his opinion and weigh in later on. But when it comes to these ethical principles in pediatrics, the challenge becomes whose autonomy are we thinking about? And we say, don't first do no harm. We certainly mean to the patient, but what about to the family? And the best interest of the patient? What about the best interest of the parent? The dignity of the patient versus the parent and the family, truthfulness and honesty. How does that play into when you're talking to a child as opposed to an adult? So that's where things get really kind of messy. And that's what I often call the balancing act of pediatrics. We, of course, have the child's well-being and interest in the middle, but we're balancing that with parental autonomy, potentially a child's autonomy if they're cognitively in a place where they can understand what's going on and be part of the conversations. Certainly a child vulnerability is at play, and how do we protect that as a society? And then what about the family as far as their importance for the child's development? And if we're going down paths where the family may not be involved in the care of the child, what does that do to our decision-making and what we're actually recommending potentially? So that's the balancing act that we face. And this is, I think, why I have a job, is because there's so many things in the pediatric world that we can offer, that we can do, but maybe they make sense for some families, maybe they don't. And then how are us as providers or other colleagues, what are they recommending and kind of pushing on families that maybe they don't want, or maybe families are demanding? And those are all things that we'll talk about. To kind of make it simple off the bat, as we heard last week, in adults, they're allowed to make decisions, right? Barb did a wonderful job of describing capacity versus competency, but in adults, they are presumed to have both of those, and they can choose to speak for themselves. If a surrogate is either assigned or we're asking a surrogate, they're supposed to use substituted judgment. What would that patient want in this situation? And that even means that adults can accept or reject life-saving treatment. We say all the time, and sometimes I have to remind my pediatric colleagues when we do have a young adult, that adults can make what we might deem bad decisions, but they get to make that if they're of sound mind. In pediatrics, in some ways, I can make it really simple and say they just don't, right? They don't have the legal competency if they're under 18. And we kind of presume that they don't have the capacity necessarily. Now, that gets a little bit tricky if you're an older teenager. One could argue that. We'll talk about some of those cases in a minute. But to make it simple, to level set, they don't have either. So it is the parents who are presumed to speak for their children and for the best interest of their children. The question we're asking is different. We don't ask, what would your 9-year-old want? Though I think maybe we should sometimes, but that's not what we're supposed to do. It's the best interest. What's in the best interest of the child? In other words, what do you want for your child is the question we ask, as opposed to what do they want for themselves. And that leads to parents having less discretion when it comes to refusing life-saving treatments. And we'll talk about some of that in a bit. Because really in the real world, then, this is the dilemma we have. It is this combination of the patient, who many of the times the patients we're following from a palliative care perspective, the majority actually won't have a say. And a lot of that has to do with the cognitive ability, either because they are too young or because their underlying illness, as we'll talk about, puts them in a spot where they will probably never be part of these conversations from a cognitive perspective. So then you have parents balancing with providers, and then what really is in the best interest of that child, and leads to questions that we'll sort of address and talk about some cases around these. Can parents actually refuse treatment? Can a child refuse treatment if they are cognitively aware and able to participate in conversations? Does the prognosis matter? Does their age matter? And then on the opposite end, can parents actually demand treatment? Do we have limitations where we can say, no, we actually won't provide this ongoing aggressive intervention? Those are all the questions that our team works with families all the time around in the pediatric world. So I think I added this to the presentation last year to try to make it a little more formal. So there are things in the literature that give algorithms and sort of frameworks for shared decision making. I personally don't find this graph all that simple, despite only being 4 steps. The first question it asks is there more than one medically reasonable option? And that is an important question, because obviously if this is a previously healthy child that has a ruptured appendix and needs to have surgery, that surgery is probably going to happen. That would lead to bigger questions if a family just flat out refuses to, bring them in for medical care. Or if your child has diabetes and is going into decay, and you decide that you are going to opt for a more natural approach or prayer over your child rather than bring them to the hospital, you will get in trouble for that. That was a real case that I encountered as a fellow when I was in Milwaukee, and that family did end up going to jail for medical neglect. But step 2 is, if there's more than one option, where does one option have more of a favorable medical benefit to burden ratio compared to the other options? The problem with that statement, I think, is the medical benefit part. So ongoing aggressive interventions like a trach event, one could have very great debates about, well, what is the medical benefit? Well, being alive. What is the burden? Well, it's a pretty massive burden. So in whose opinion does that balance shift? And that's sort of the heart of what we do. So I don't necessarily use a framework like this. I think it's innate in what we do as a palliative care team when we work with families, but there is more sort of evidence out there as far as how to do this in a more academic way, if one chooses. Before I talk more about some of those decisions and things, I do think it's important to comment that there are limits to parental autonomy. So certainly our team, and in pediatrics in general, and medicine in general, we don't endorse things like physical abuse or neglect. And we don't have to look very far to see examples of that just in our own backyard. These are 2 cases from the past several years of families being found guilty of murder for things like not feeding their children or locking them in a basement or a cage to punish them. Those types of things. So certainly those are not things that we would endorse, and there are limits to what a parent can do or not do. And then the question of controversial practices is always interesting in my mind. This is across our state. Several years ago, there were doctors charged for female circumcision, which is a sort of accepted cultural practice in some areas. These doctors were charged. So is that allowed or not allowed based on what the family is asking for? They were charged, but then 2 years later, the charges were dropped as it was deemed that it is an acceptable cultural practice. Again, a lot of debate around that, but I just put it up there to sort of mention that there are some pauses we have around parental autonomy. And the other important part of that, and these are newer slides compared to last year because we've learned a lot even more recently, our team, the vast majority of patients we follow from a palliative care perspective have what I would call severe neurologic impairment, meaning a brain anomaly, a brain injury, a progressive neurodegenerative condition, a metabolic condition of some sort, where they, again, are not going to be part of the decision-making process, kind of almost regardless of their age. But in those patients under 18, the parents, again, like any other child, are presumed decision makers. The parents are legal guardians. They're the decision makers medically and otherwise. So that's kind of straightforward in our world. The parents do get to make those decisions. We work with the parents around what their wishes are for their children based on goals, values, beliefs, the usual stuff we do. An important caveat for people to be aware of: children in the foster system, that is not true. So even if foster parents have physical rights, the bar to take away a parent's medical decision-making rights is remarkably high. So we've had situations of non-accidental trauma that the parents, who may be the ones charged with that crime, are the same ones being asked to make a decision about continuing a ventilator via a tracheostomy, which one might imagine creates a very interesting dynamic around conflict of interest and whatnot. But even outside of that extreme, if we're following a patient who is in the foster system, the actual medical decision-making rights, obviously emergency things that foster family can do, but certainly when it comes to bigger decisions about end of life or, stopping aggressive measures, foster parents do not have those medical rights. In a similar way, and I think what's really important for adult providers to understand is that same patient I described in the first bullet point, who we may have followed for 10 years, working with the family around goals of care and perhaps would they intubate, wouldn't they intubate, even DNR. We may have a patient who is a DNR under the age of 18. When that patient turns 18, the parents, one, have to go to court to get legal guardianship. That's a very common thing. And our social workers work with families and try ahead of time to remind them of, hey, that 18th birthday is coming up. We need to start that process. But the other really important part is the end of life decisions, including DNR, may look significantly different. Barb mentioned last week that there are some mechanisms that when a guardian is appointed, that it can include end of life decisions. My experience in talking to our team here is many times that's not the case, and you do have to go back to court to allow a DNR to be signed when a patient is closer to end of life. The challenge is for those patients that we follow, what is closer to end of life is really questionable, as we'll see in a little bit. So trying to do advanced care planning in this population can get rather tricky because, yes, they're a vulnerable population, but it is a little bit odd that the moment they turn 18, suddenly it needs to go through court. But before 18, it went through that parent. So just to be aware of that there are some hoops that we may need to jump through to continue that process of advanced care planning and helping parents or guardians figure out those next steps. The one question that I have about this involves hospice enrollment, because I have had patients who are on hospice when they're under 18 and then they turn 19. And quite honestly, maybe I should admit this, we don't do anything different. We don't go back to the court. And what's a little bit odd is I think some of those court orders for a DNR need to be there, but I've never heard of that needing to be the case to enroll someone in hospice. And those of you in the adult world maybe have examples of that or not, but it's sort of an interesting little thing of, okay, you need the judge to say the patient can be DNR, but I don't think you need the judge to say the patient can be on hospice. And you don't need the DNR to be on hospice. So it's an interesting sort of area. Again, I don't want to seem neglectful or not respecting a vulnerable population, but the under 18, it's completely the parents. Over 18, there's some other steps that may need to take place, which makes things interesting. So on to some of the questions that we face around that whole refusal of treatment. Again, the adult world, patients can refuse chemotherapy all the time. We may not agree with it, but they have the right to do that if they're of sound mind. What happens when you're a child? These are actually just a smattering of cases from the last bunch of years. I should probably find more recent ones even. But I've always thought as an oncologist, there must be an age or a prognosis where stuff will, of course, be, I dare say, forced upon a family, that a family can't choose to not do chemotherapy for their child with a very treatable cancer. But unfortunately, the legal cases out there are all over the place. The top three are ones where it was allowed for a family to forego chemotherapy. The top left is actually a patient from our own community, treated at our institution. They're actually from the UP. This was probably 15 years ago. 10-year-old male with rhabdomyosarcoma, 70% survival if completed full chemotherapy. After the first 2 cycles, there was no evidence of disease. The family said, we're done. Now, the problem is we have research to say that if you stop after 2 cycles, it will come back and your survival drops to probably 20%. But the family said, no, we don't want to do this anymore. Chemotherapy was awful. There's no evidence of disease. They went to court because the oncology team here took them to court and they lost. The judge said the family does not have to continue chemotherapy. So 10-year-old, right, with a pretty good prognosis, can refuse. Well, 70% may not be fantastic. But if you move on to star child Abraham Chirix, was a well-known case in Virginia, now 20 years ago. He was 16 with low-stage Hodgkin's. As probably all of you know, that is remarkably treatable. He got one cycle of chemo with some pretty bad side effects and said, I'm done with this. I don't want to do it. His parents supported him. And that actually led to a law in Virginia called Abraham's Law that allows a mechanism for families to refuse treatment like this for their child. Interestingly enough, he did end up with a bone marrow transplant later when he was over 18, when his disease did come back. So he made some different choices later when he was over the age of consent. Again, Dennis Lindbergh is an interesting case of a 14-year-old with high-risk ALL who refused a blood transfusion as a Jehovah's Witness in Washington. He was in the legal custody of his aunt, who was a Jehovah's Witness. His parents were not involved in decision-making, but they and the hospital went to court to try to force a blood transfusion, which actually there's a pretty clear mechanism on the heels of that famous case in Massachusetts in 1944 that says parents can't make martyrs of themselves but not their children. So the blood transfusion to Jehovah's Witnesses' children is actually a relatively common thing that we have a way around it legally. But in this case, the judge sat the 14-year-old down and deemed that he was making this decision himself. It was not an undue influence of his aunt, and they allowed him to forgo a blood transfusion during induction chemotherapy, and he died soon thereafter. With something that probably has an upwards of 80% survival. He would have been high risk because of his age, but still over 80% survival. But then the bottom cases are actually ones where judges did not allow that to happen. Daniel Hauser had low-stage lymphoma. His mom took him out of the state of Minnesota, kind of on the run. They got caught, dragged back to Minnesota, and legally were forced to do chemotherapy. Similarly, the middle case in the bottom, a 9-year-old with severe autism, developmental delay, got acute leukemia. Mom went to her appointments and got the medications, but never gave them to the child. Needless to say, she got in quite big trouble for that. And then the last one on the bottom is what I find kind of almost more interesting. So if you look at the age, there's no real clear age or prognosis that would dictate one way or another. I still have to believe that if you're a 5-year-old with acute leukemia and your survival is 97%, that you are going to have to do treatment on that child. I've not seen cases where families have refused. I don't know how well that would stand up in court, but these cases show it's a little bit all over the place. The other end that's always fascinating to me is how in the world can you force a 17-and-a-half-year-old to get chemotherapy against their will? Well, if you're in Connecticut in 2015, you can. This Cassandra was a 17-year-old with, again, Hodgkin's lymphoma, very treatable, that said, I don't want poison in my body. She was like 17 and a half, I believe. Her mother agreed with her, but they were taken to court by the hospital system. And the judge said that the young woman was not showing that she was a mature enough person to make the decision because she wasn't going to her oncology appointments. They put her in the hospital with an armed guard at the door. There were some reports that she was actually in restraints in the bed while she got chemotherapy, which is just mind-boggling to me. Because again, if this was 6 months later and she was 18, the comment might be like, well, this seems like a bad decision, but you're 18, right? So that age, as you get older towards 18, is really an interesting sort of age range of, do we allow children to make that decision or not, which really begs the question of age of consent, which is obviously a much bigger conversation of, do we actually expect teenagers to make rational decisions? We're all well aware that the prefrontal cortex doesn't develop until age 25, probably even later in males. So, but at 18 is a magic age where suddenly you get just to decide. So it brings up some really good ethical questions of, like, that young lady at 17 and a half, that state, though that court system decided she was not capable of making the decision. But if she was 18, you probably wouldn't have anything to fall back on unless you deemed her not competent, really, to make that decision, which I don't know that would hold up in court. So how do we handle a 17-year-old versus an 18-year-old? The question is, I don't really know. I think that would be obviously case by case, with ethics being involved, with legal and risk being involved. And of course, a minor can become emancipated. There are mature minor statutes in different states. Again, Connecticut ruled that she wasn't mature because of the decision she was making, which I think you could argue about plenty of even 18, 19, or 20-year-olds as well. So, So overall, from a refusing chemotherapy standpoint, there's not really a precedent that a certain age or certain prognosis matters. It is really case by case across the country. But what about other life-sustaining treatments? Can families refuse that? So moving away from chemotherapy into an area that, quite honestly, our team deals with far more often is, can a family refuse other aggressive measures that have been started? So this is a case from years ago, but we've repeated these conversations with, unfortunately, many families throughout the years in our neonatal ICU. A child born with severe prematurity, living into all the complications thereof 6 months in, on high levels of respiratory support, and headed towards a trach vent to be able to leave the hospital. This particular mom asked the NICU, what if I want to stop? This is 6 months in, and she said she feels like her child is just an experiment and has a terrible quality of life. Now, all of us listening to this call hopefully would answer that question with, tell me more. Why are you feeling about that? Right? Explore that more. Unfortunately, that was not the NICU's response. The NICU said two things to this mom at that moment. You should have told us that in the beginning. Why did we start this if we're just going to stop? I've heard that from the NICU and multiple times around similar situations. We started all these interventions. If you didn't want to start at 22 weeks, why did we do this? Now, 26 weeks actually is severe prematurity, but survival and morbidity is actually quite a bit better than now. We're down to 22 weeks very commonly, or 23 weeks very commonly, similar with not great survival and certainly very high morbidity. And that notion that, well, you should have told us in the beginning as opposed to now is a little bit silly in my mind, but we still deal with that literally to this day in the NICU. And obviously I'm biased. I do think parents have the right to make that decision. And I know whenever we present these cases, I feel like because our fellows, whether our peds fellows or adult folks rotating with us, will present these sometimes. And I know all of you understandably start with the question of, well, what's the family's goal? And well, sometimes the family's goal is absolute length of life. It is to avoid death, which takes us down one path. And then sometimes families do question it about the quality of life. But the question is, whose opinion of quality of life? Some of my colleagues in the pediatric world will say, well, it's just a trach. Most families don't want one, but they learn to like it eventually, which is kind of an odd statement for a very much life-changing intervention, let alone if you add a ventilator to that to have your child survive, especially in a situation where you're not expected to come off the ventilator eventually, right? So I think this is where we run ourselves into problems. And the heart of what we do for a lot of families is trying to navigate these conversations about, what does quality of life mean to you? Is it length of life versus quality? And how, for that individual family, does that dictate then their decision making? And one of the other questions I always like in these situations, that last one, is, can a family even take care of a child in that situation? So if they're feeling like they're pushed down this road of long-term mechanical ventilation, because that's just what we do, and you started it in the beginning, so now you have to continue, is that fair to the family? One, but I often will ask referring providers, because they want us involved because the family is, being, quote, difficult. I'll ask them, do you think the family can actually care for this child in this condition in this situation? And very often, immediately, their answer is no. Well, no, probably not at all. Well, to me, that's a really big ethical question of, should that not be part of the conversation? If the decisions you're making now could potentially lead you to your child not being in your care, should you not be aware of that? And then I get pushback from folks saying, well, no, we don't really know that, so we can't talk about it. But we kind of know it's a possibility. So it makes me really nervous how we kind of blindly go down these paths sometimes. But moving on from that to an even maybe more controversial topic to touch on, the trach vent conversation is one we have a lot with families. But what about that case I started with? Can a family choose to stop artificial hydration and nutrition for their child? Obviously, I think I'm preaching to the choir about this overall. Most people on the call probably are like, well, yeah, that sounds like a terrible situation, and prolonging it is not necessary. But the fact is, in the pediatric world, it becomes a little more controversial, or at least a lot more opinionated by people who accuse me of doing underhanded things when we talk to families about these artificial interventions. And then how do you include his voice in that conversation? He's a 16-year-old. He does not have the legal competency to be part of it. Does he have the capacity or not? I won't belabor the story, but this became very complicated because ethics wasn't involved. And ethics and psychiatry basically said, well, he's too depressed to make the decision. Now, you heard me kind of quickly describe his condition. I don't know how one wouldn't be depressed living in that condition. I don't think there's any amount of counseling or SNRIs that are going to make him feel better about his existence at that point. So I found it really frustrating and interesting how those conversations went. But the fact is, there are actual guidelines out there that I always share with those people who rotate with us, because I don't think this is talked about anywhere else in the pediatric world, certainly. But the AAP has guidelines around foregoing medically provided nutrition and hydration for children that I love sharing those with both our learners and my colleagues around the hospital when these conversations come up, because it makes me feel like I'm less crazy. I didn't make this up. There is guidelines that, yes, there are populations, and this article is great. It gives 3 different sort of populations of kids who will not survive their neurologic condition, who are in a minimally conscious state, where artificial nutrition does not have to be continued at all costs. So I very much appreciate these guidelines that do paint a picture of it can be considered. It's not recommending it, but it says it can be considered. It is okay. It is legit to consider cessation of these artificial interventions in these certain patient populations. Maybe not surprisingly, the other reference there from the NHPCO is much bolder in their statement that if the intervention is not helping, including artificial feeds, if it's not helping the underlying condition get better, it should be stopped. I appreciate the boldness of the statement, but it's perhaps a little too bold for most of my pediatric colleagues when it says, well, clearly the feeds aren't fixing the brain injury, so they should stop. Not usually how we have those conversations, but the pediatric guidelines have certainly been helpful. I've stuck them in charts before when we had charts, just so that other providers understand where we're coming from, and we're not just trying to shorten children's life just randomly. So flipping to the other direction, what about when families demand ongoing treatment? What do we do in that case? Do we have a way to say no? Can a medical provider refuse life-sustaining treatment? Well, obviously, right off the bat, we all have the ability to say no to things we don't feel are ethical or whatnot. But overall, as healthcare systems or a children's hospital, how do we approach that? And again, this is not an uncommon situation that we run into several times a year. This particular child was a newborn baby, severe brain anomalies, basically missing almost his entire brain. It was a giant cyst with a little brain stem. Immediately intubated after birth, high levels of respiratory support. The NICU literally documented anomalies not compatible with life, and they recommended removal of technology and allowing a natural death. The family flat out refused. And this is not, I mean, this again, I'm describing one case, but I could describe multiple others over the years as well. So it brings up the question of futility, which nobody wants to talk about. I refer to that as the F word because nobody wants to talk about it. Because one, we don't have a futility policy at our hospital. The state of Michigan does not have a futility policy regarding this. The state of Texas has the most kind of well-known futility policy, in my experience, where 2 providers can say this is futile, and the family, I believe, has 72 hours or something to find another institution to accept that patient, whether it's an adult or a child. But this is a scenario I find interesting, that we say not compatible with life, but what does that mean if you have a ventilator, right? That changes one's prognosis quite a bit, and we can keep children alive for quite a long time. Now, that's how our country tends to approach it. It is interesting, you go down giant rabbit holes online around how other countries, in particular England, approaches similar situations. Some of you may be aware of the Charlie Gard saga, which is one of the more well-known ones in 2017. There have been multiple other similar examples since then, mostly out of England, of children with known neurodegenerative or terrible metabolic or genetic diseases who are not getting better, who are stuck on ventilators, and the National Health Service says we're stopping. And this particular case, the family fought it on multiple levels throughout the courts of England and Europe, and they lost every time. And again, not to belabor a longer story, there was lots of things in the lay press and on Twitter and people tweeting out, "Oh, save Charlie." I think the president at the time tweeted out, "Save Charlie." The Pope tweeted out, "Save Charlie, bring him to our hospital." Someone at Johns Hopkins said, "I'm doing treatment or doing experiments on mice with a similar neurodegenerative thing, not his, but come here, we'll give you the medicine." They raised a bunch of money on GoFundMe to do it, and England still said no. And eventually they did stop the ventilator and he died. But so sometimes I think, well, that's horrible. Nobody wants to be in the news. But sometimes I do feel like that approach of drawing a line and saying there are things that we will not offer and we will not continue. it's awful and terrible, but also maybe takes that burden off the family's shoulders where they're not in a position to be able to demand things that simply may not make sense. But that's not how our system works. When you talk about futility in this country, it's a much different conversation. We don't really have that leverage to lean back on. A lot of this has to do with truthfulness and honesty. I think when we talk about prognosis in pediatrics, we don't do ourselves any favors when we don't admit what we don't know, or we say contradicting things among our teams. So again, this exact scenario, I have dozens of examples of over the years. 6-year-old girl, severe intracranial hemorrhage, minimal brainstem function, no purposeful movement, kind of like the child I just described in the last case. Neurosurgery and PICU were united in telling the family this child is neurologically devastated and is not going to wake up. But neurology said a statement similar to this. There's a small chance that she might have some limited improvement. I don't know how people, I can't see people's faces and stuff, how you react to that statement. I don't know what to do with it. There might be kind of a chance maybe.
A lot of jaw dropping on that one. And I know you're getting into this, but those are the things that, on the basis of what are they able to make that statement is what it gets down to from my perspective.
Yeah, absolutely. And I took out a different reference I had because there are some interesting studies about, and I think we all know this anecdotally, but anecdotes and the power of anecdotes and how it influences decision making. And what I've heard neurology, and I won't just pick on neurology because I've heard opposite situations where neurology says your child won't wake up certainly in a meaningful way, but then neurosurgery will say, but one time I had this kid with the same MRI and they're walking in my office. Right. That's great. I'm very happy for that child, but you've also seen the other 100 or more that aren't. And I've had very smart physicians tell me, who am I to be the one to take away their 1 in a million hope? Well, you're a smart neurologist who has seen the other cases where unfortunately it doesn't happen. So it's that classic balancing hope with reality. And this is the part of the talk where I probably lose whatever credibility I had, because as I've done in the past, I will quote the movie Dumb and Dumber, where it's basically, so you're saying there's a chance. And I'm not technologically advanced enough to play the video, but those of you who've seen the movie, he asked, do we have a chance to be, together romantically? And she says, it's not good. He asked, what do you mean? Give it to me straight. And she says, 1 in a million. And he pauses and smiles and says, so you're saying there's a chance. And that's kind of the similar notion in these cases of, we want to be honest, we want to be truthful, and we can't hide behind the 1 in a million chance. And again, there are situations based on what I just said above of what families can demand, where even if we tell them that and we are unified about the likelihood of a child recovering or getting better from whatever condition, that a family will still demand to do absolutely everything. And we are sort of stuck in those situations of okay, well, we just keep moving. There's a child in the hospital right now who's been there for probably a year, going on a year, who the family won't stop aggressive interventions and can't take the child home because they can't find home nursing. So the child just lives at the hospital for, ever, apparently. So this is the challenge. And I tell my colleagues all the time, unless we are in a unified approach and not saying these statements that are contradicting ourselves, we can't expect families to move to a different spot. And all it takes is one provider for that family to say, yes, but Dr. So-and-so said they might get better. So that's what we're sort of battling against. Now, I often say that we should at least be better about brain death, right? If we declare a person brain dead, we at least have that figured out, correct? And the answer is, well, unfortunately not. This is actually 2 cases from our state in 2019. 2 teenagers, both declared brain dead after different scenarios, one in Royal Oak and one in Ann Arbor, 70 miles apart. I did the math at one point. Both declared brain dead, both families fought it, both went to court. And the one, I believe in Royal Oak, said, nope, you cannot take that child off of life support. You have to do surgery, trach, NG tube, before transferring to a facility of some sort, which is a whole nother conversation because we don't have long-term care facilities for children in the state of Michigan. But the other judge, 70 miles away, said, no, the family can't demand that. You can take the child off because they've already died. And they did, sort of against the family's wishes. So even with something that should be kind of as clear as brain death, we can't legally necessarily lean on one outcome or the other. A little bit on informed consent. is another sort of thing I question a lot, right? We all are well aware of what informed consent involves, the risks and benefits of proposed treatment, what are the alternatives, and that you have the right to refuse that proposed treatment, that this treatment is voluntary. I'm not saying you have to do it. Now, again, there are caveats that, as I mentioned in the beginning, but if we really talk about informed consent, I think much of the time in pediatrics, we forget that last part. And a good example of that is our patients with severe congenital heart disease. Hypoplastic left heart syndrome is something that we're consulted on ideally all the time via MFM and our cardiology colleagues even before a child is born. But what's interesting about that diagnosis, the surgery has gotten better, don't get me wrong, but it's still not a slam dunk that this is perfect. That is 3 surgeries within the first several years of life, followed by a heart transplant in your 20s, typically. And some families, it is an appropriate decision to say, I'm not going to put my child through that. That is an acceptable option. But what's interesting, now this study is a little bit old, it would be interesting to see if it's changed at all. When this condition is diagnosed prenatally, only 35% of providers discussed all the options, including not doing the surgeries. If it's diagnosed postnatally, only 14% discussed all those options, which is really interesting. Of when you find it, somehow you feel you can't offer the sort of comfort care option if it's diagnosed postnatally, even though most docs wouldn't even talk about it prenatally, which is fascinating. The other caveat to that is when you ask the heart surgeons or cardiologists themselves what percentage would choose surgery or not, it's a very significant proportion that would not choose to put their child through that surgery, which is really interesting to me. Of what would you do if it's your own child? And if that's on your mind, if I wouldn't do this for my child, but I'm not even going to mention to the family that it's an option not to do it, that's a huge red flag. And I've heard this in other areas as well, of neurosurgeons or other folks saying, boy, I wouldn't do this if it were my kid, but that's never sort of shared with the family. And I get it. We can't put our own values on a family, but if you have a person who wouldn't do this for their own child, I feel like that somehow should be part of the conversation, at least that this is an option to not go down this path, or make a family feel like this is just what you do. So overall, that really is the problem in my mind of being a child. And those of you that spend time with us know I say this all the time, that there's a bit of ageism involved. This adorable little boy, if he had a devastating brain injury as an 8-year-old, I realized he looks younger than 8, so forgive me. I just found him out way. Secondary and MBA, we very commonly will act like G-tube, trach, vent, and time will tell. Right? We can easily paint a picture of, well, we're not really sure what this looks like, so this is just what we do. Now, I will say that over the last several years, I feel like our PICU has evolved a little bit around being more open around, does a family have to do these things or not? Ideally, I like our team being involved to help navigate that because of the turnover in the PICU as far as attendings and different things. But we very commonly still land here. Well, we're not really sure, right? Children's brains are very plastic. They might get better. We don't know. So this is just what we do, and we snowball and go down this path. What I always say is, if Eli instead looked like this adorable gentleman and was 80 instead of 8 with the same devastating injury, do we view it the same way? Now, I'm not saying that there aren't families or patients who demand it all the time, but I feel like as an institution, as a society, we do view it differently if you're 8 versus 80, because we say things understandably that, well, this gentleman had a good life. He got to experience life, right? Versus the 8-year-old hasn't experienced that. So we somehow feel compelled that we have to do more just in case he might get better someday, which I don't know is a fair thing to put on a family's shoulders. Well, I do know it's not fair to put on a family's shoulders. So to me, it's the web that we weave for some of these complex kids, especially with neurologic devastation from whatever the cause, be it a traumatic brain injury or HIE at birth, or a known neurodegenerative condition, or a known chromosomal anomaly, or anatomic brain anomaly. A family chooses aggressive measures, G-tubes, trachs, long-term vent, not knowing actually that they could have made a different decision, or feeling pressure that this is just what you do. This is what care looks like. Your child's stuck on a vent, now they get a trach. And then later, when the child's in the hospital over and over and over again, we hear our colleagues in the hospital saying, why are they putting their child through this? Don't they get it? But the issue is we started in the beginning by not actually talking about what this looks like. Will that ventilator fix your child's brain injury? Well, it won't, right? So I talk about this web we weave because we sort of create the problem by not having open conversation ahead of time. And at the heart of it, and I tell families this all the time, some of you have heard me say this, I made this up, but I tell families that our team specializes in uncertainty because I don't trust, no offense to my pediatric colleagues or ICU colleagues or anybody else, but I don't trust what they tell me because I've done this for too long to know that the prognosis they gave a child may be way different. And one of my favorite things to do in a lot of kids that we see, even if they have a known diagnosis, a known genetic diagnosis, and I think this was taken from like Wolff-Hirschhorn syndrome, which is something we've seen quite a bit. Obviously, any rare genetic syndrome can have a variety of phenotypes, but when you read smart websites like raredisease.org, which is out of the NIH, it'll say things like this: prognosis is variable, with most children not surviving past age 4 to 5, but the reports of survival into adulthood, which again, I kind of could guess either your child will die early or they won't, right? That's kind of what that says. And where in there does your child lie? Well, guess what? We're not smart enough to tell you. And I am a huge fan of humility in general, and humility in medicine to admit we're not really sure. Like, I think because of X, Y, Z, I'm worried that this might happen, but your child may live way longer. And we see this happen over and over again in our patients. I just had a patient that passed away on hospice with Zellweger syndrome, the prognosis of which is 12 months of age. She was diagnosed at 8 months, and she died at 19 years. So had the same thing, had all the sequelae, had all the bad stuff, but for years and years. And yes, she had a trach at age 4, but she was not ventilator dependent. So some of those interventions might prolong things, but we also have to admit that we simply don't know, and we have to ride those waves of uncertainty with the family and not pretend like we know exactly what will happen. And then the second comment I find interesting as well, for many of these rare diseases, we can do way better genetic testing than we used to, which is awesome, but also, again, no offense to genetic people, they're probably not watching this. Also was rather disappointing because we can name it. Great. Can we do anything about it? Probably not. Right. And then what happens? Well, you might have all these, there's 10 people in literature to have your rare thing. You might have some of this, you might not. It's really up to the child. And we tell families all the time, your child will tell us what this looks like, because the literature will say things like neurologic sequelae vary from mild to severe, which again, I don't know how to help counsel a family that there might be bad stuff, there might not be, which we kind of knew. But that's the uncertainty part. So when it comes to advanced care planning, how do we kind of approach this? Well, it's not nearly as simple as, well, what do you want done, right? We ask questions all the time about what have the doctors told you about your child's prognosis. As I mentioned, one of my favorite things to hear from a family as well, they said they wouldn't live past age 2. That's interesting because now they're 10 or 12 or 15. They still have the bad diagnosis. The prognosis is more based on what their body is telling us, correct? So we have to do some correction there and admit like we were wrong or we don't really know, and not set firm timeframes. I think we all know that, right? Similar to, oh, this patient will die in 2 months. We don't tend to say those things. I would argue the same thing for these kids with rare diagnoses. They might die early, but their body will tell us what this looks like and what are their needs. And how does a tracheostomy and a ventilator change one's prognosis in a rare genetic disorder? I don't know. Makes it better, I guess. They'll live longer, but how long? I don't think we certainly don't know that. But then I ask families, would you pursue aggressive interventions for your child should they require intubation or cardiac resuscitation? Now, I don't say it like that, right? I say it in different ways that don't sound so robotic. But when we ask those questions about intubation, if their child needs it, I almost across the board, I've never done the study, but I'd like to. I'm guessing at our children's hospital right now, if not 100%, probably 99% of kids, the answer is yes, they are full code. So that's what families will say. But the second most common answer I get is it depends. And what it depends on is it reversible or not? Now, the challenge is, I tell families all the time, I'm not that smart, but even the smart ICU doctors, the smart ER doctors probably can't tell you if this intubation is reversible or not. There may be some evidence that, boy, last time this happened last month, we barely got off the ventilator, right? Or your muscle weakness is so bad, I'm worried your child will never come off the vent. Those are conversations we have to have. But more often than not, those are the two answers I get from families, not a no, I would never intubate, right? But the next important question that we then ask is, would you be able to stop an intervention once it has started? And this is, I think, a really powerful question, because if a family tells me no, I think that's a huge red flag to pause, right? And I have a child right now who's been on hospice for 4 years with trisomy 18 that has actually been back to the hospital to treat pneumonias and different things, which is allowed with concurrent care. Stay tuned for January to learn more about concurrent care and how that is confusing and beautiful all at the same time. But the fact is that family would not intubate their daughter because they do not want to have to stop. And they know if she is intubated because of her underlying condition, there's a real chance that she will not come off the ventilator. And for them, emotionally, psychologically, it's too much to to take that ventilator away. To me, that's beautiful advanced care planning. Doesn't mean they're not going to come to the hospital to be on CPAP or BiPAP. No. So that's, I think, a really important question, that if a family says, oh, I couldn't imagine taking them off. Okay, well, then are you prepared to then go down the tracheostomy route, right? Because if you're not, that's going to be a big conflict that we'll have to work through. The other thing that I'm passionate about, and our team is actually, with the help of our wonderful fellow, trying to do some process improvement around our trach vent discussions with families way upstream, not with the goal of talking them out of it, but having them feel better prepared. I think an important part of that is a statement like this. There will come a time when I should probably take out may, we will need to talk about whether this intervention is still helping. I think we paint these interventions at the front end like they're great and think they're going to change everything and cure an incurable disease, which is simply not true. And then families seem shocked later by, oh, wait, I thought this was going to change this condition entirely. So I'm a big fan of presenting this statement somewhere early on of, at some point, that ventilator, because of your child's condition, simply won't be helping. And we're going to have to talk about that, rather than being surprised years later that their child continues to decline. So my statement about advanced care planning really in pediatrics is not about the answer. And I think I got myself into trouble some years ago with the folks who were from Making Choices, Michigan, and that, even at our own system, they wanted to include pediatrics. And I was like, I don't know a single family who has their documents done of, I will never intubate my child. Like, show that at the ER and be done. That's very rare. It's much more situational. And I think it's about the journey and the conversations, not the absolute answer in that moment. If a family says, I don't want to bring them back to the hospital, I don't want to intubate, to me, that is a trigger to talk about hospice. And so for most of these kids, though, it's about the journey over years, not necessarily the answer at that moment. Because a lot of it goes back to what does it mean to be a good parent? And there's a lot of literature around this. And this is the conversation we have with families when we have this advanced care planning kind of conversation. They're still hoping for a miracle. They're still afraid of giving up. What does that mean? What does a miracle look like to you? Maybe a miracle looked different 5 years ago than it does now in your mind. I never want parents to have regrets, either by doing too much or not doing enough. And I think we have a tendency in pediatrics to assume that a parent will regret if their child dies and they didn't do enough. But I've met plenty of families where it's the opposite. They're actually worried about pushing too far, and they need help knowing, when do I have to draw the line? That loving decisions comment is a I don't want to say line. It's a statement I've made to many families over the years. In a weird way, those of you know me, I love what I do in a weird way, to be able to help families on this journey and have these conversations, including when I can look at them and say, the most loving thing you can do may also be the most horrible thing you can think of, and that is stopping. But I've said that to many families over the years as a way to help them understand, like, this is terrible, it's awful, but also very loving to say, I've put my child through enough. So that's the balance that we're trying to do in working with families, and why, at least in pediatric palliative care, sometimes these are conversations years in the making. Certainly 2, 3, 4, sometimes 5, 6, 7 years of conversation until it's very clear their child is closer to the end of life, or they're at a point where they don't feel they want to keep pushing in ways that aren't helpful. So again, I can make it a little more academic, and there's literature to support this, with the patient and family in the center, surrounded by hopes and goals, values and beliefs, quality of life. This is very palliative slide, right? This part is no different than the adult world. It's just the emotions and the logistics around it from a pediatric perspective do feel different because it's a child. But there are resources here if people want a little more evidence-based approach than our anecdotes. As Barb mentioned last week, I think she brought up 5 wishes as an advanced care planning tool. I've used this before with teenagers, but thankfully the same organization that made this has 2 more versions as well. One is called Voicing My Choices. They took 5 wishes and ran through it with teenagers with serious illness who were cognitively aware and able to participate, and they changed the language into more teenager-friendly or young adult-friendly language, and that's the Voicing My Choices document. They also have a more child-friendly version, which has big spaces like that white spot where kids can actually draw pictures of what's most important to you as your disease gets worse. Who do you want to be there at end of life, right? Hard conversations, but there are tools out there that help with those conversations, even in younger ages. So how do we best support patients and families? Well, it's obviously this is, you all know this, it's open and honest communication with family and between medical teams. And that's something we run into all the time with our medical providers giving conflicting advice to families. You need a trach. No, you don't need a trach. That was one from just last week. What's a family supposed to do with that, right? So we are kind of the clean slate middle person. A family told me last week that actually they recommended, it's a family that has 2 children with trachs and vents at home, who we've known for a long time. They recommended us to another family, and her words to the other mom were, they're a great blank slate to allow you to word vomit on whenever you need to. I was like, I love that. That sounds gross, but I love it because it's really true. Like, we're there as a blank slate to try to help take that burden off of families who aren't feeling like they're on an island. The other comments about ethics consults, when it comes to some of those situations of, okay, the teenager is refusing treatment, or what's their voice look like, sometimes ethics consults are helpful. I say question mark because I think more often than not, the ethical dilemma around some of these situations is more moral distress of a given provider or staff, as opposed to a true ethical question. I firmly believe that families have the right to make these decisions. The fact that another provider, a nurse, an MA may make a different decision for their child is not really an ethical question. It's more moral distress, which is still very, very important to address. I mean, we do a lot of education around the hospital. This is why a family's choosing this, and it's okay. I understand that it bothers you, and let's talk about it. And that's all part of the education of other providers as well. So I think that's all I have. And it might be the first time ever I finished early, which was intentional, because I do want to have more conversation. But I do say, I think every time I've given a talk over the last 9 years now, we've been doing this, I include pictures of my family, which those of you, maybe some of you know this, has expanded as of last summer, finally. So we do have a 5th child, JC, on the right there. This was my now 11-year-old's birthday from last month, which is shocking because he barely existed when I first started working with the fellowship. But we added both another child and another dog to the mix since last time I spoke to you all. So thank you for your time. Happy to take questions or comments from those of you who are more experienced and knowledgeable than me.
Thank you, Brad. I'm not sure about that more knowledgeable or experienced. We just so appreciate this, and it has value for all of us well beyond the pediatric realm in terms of just understanding the aspects of communication and how to approach families. We get that. I think that you had the picture of the 8-year-old and the 80-year-old. Doesn't matter. The issues are the same. The decision-making trees are the same. And I think that your comment from the family about your role in terms of helping families process that is dead on. We've had this conversation, but I remember from all my years working in ethics, one of the most common things that I would see is that when an ethical case would, when a case would come to ethics, in many circumstances, my initial reaction was, they don't need ethics. There's not an ethical issue here. What they need is a good palliative consult. What they need is effective and honest communication, and how often that is. So anyway, I appreciate that. I'm going to make just two other quick comments and open it up to the floor. When we talk about age of decision making, I have, and I know you have too, Brad, and Matt sitting here in front of in front of us as well, seen 7 and 8-year-olds who have wisdom well beyond their years, and often wisdom well beyond our years as well. And so the opportunity to give them voice and listen to them, regardless of the legal status, I think is always important. The other was just a case we had here in town about 15 years ago, very similar to a couple that you mentioned. This was a young woman who had been diagnosed with early stage Hodgkin's disease and just elected not to have treatment. No rational reason why. I just don't want to. She was flippant. She was pre-adolescent in terms of her process there. Interesting, she had never been diagnosed with any sort of developmental delay, anything of that sort. But her attitude, behavior, language clearly was earlier than her stated age. Her parents were very concerned that she was electing not to get treatment, and did take it to court, did have this girl committed, and she received her chemotherapy over Pine Rest under duress and in opposition to her wishes. There are weird things that happen on the adult side too, and simply because her behavior and decision making was more consistent with the pre-adolescent, the court said that that's relevant in addition to just what her chronologic age is. So anyway, I'll stop there. Comments and questions for Brad. Floor's wide open.
Matt, I feel like you want to say something, Matt.
He's itching.
No, I always like to try to keep quiet because this is kind of like where I kind of sit, right? I will say though, Brad, first of all, you're an incredible presenter. So I just wanted that to be said. I think anybody that doesn't have an interest in peds should be able to hear the passion and understand what we on the pediatric side face on a daily basis. And it's not easy because it really feels like even with our colleagues sometimes, as much as I try to be open and positive, I feel like that, you know, that what is it that I actually do and what I do try to do, it's like you're just trying to push somebody away from treatment when the truth is it's staring you right in the face, right? I mean, the child is dying and I know this is easy, but one of the things I have learned through my time with this, and I know that you and John have had a lot more time doing this, but I have learned to take that word fair and throw it right out the door. And I know that sounds like kind of easy, but I think that that's what hangs not only parents, but providers. We have this sense, you know, that grandma, dad, mom, then child. But I try to sit in the thought of why does it have to be 80 before I'm supposed to die? Now, it doesn't make it easier, but it makes it more real in the sense is that we all have disease processes. We're taught that in medical school, right? But then we're supposed to be saving everyone after if it's a child. And I'll be real brief. I was telling John this morning, you can see how this can get real interesting, even with parents. I have a child that came to me for a compassionate extubation just 2 days ago from Riley's Children's, 70-year-old, factor V Leiden, had a cardiac arrest and then a anoxic brain injury. And the mother was absolutely able to sit in her grief and say, yes, we need to do this. I don't want her trach. She didn't want this. I didn't want her G-tube. Fast forward, I got called this morning, I'll talk to you about later, but there's a patient here on the Michigan side, 17, traumatic brain injury from a car accident. And yet the mom is full court press and the staff, I think, is having trouble saying no. And so it's really funny how this all plays out. And is it the provider? Is it the family? Is it again, that's where the complications come. And I'll just end by also saying, though, I don't think it's so generalized to say that you get all these difficulties on the pediatric sides, because I've actually had more difficulties with adult patients, elderly, with trying to deal with their family who don't want them to die either. And they're sitting there 95 and you want to do a chemo on them, right? So I don't think that there is an easy, I don't think there's a fair, but I think that we need obviously to do what we do, because without that, the patient is kind of left without a voice. That's just my take. But anyway.
But you know what, I'm always saying this because I heard this little snippet on a story on the radio on the way in. And because hopefully, Rich, I never wax political in any forum that has any publicity to it at all. But part of it was just sort of a debriefing on how the election went the way that it went. And this particular commentator said that Trump's comment was that what's happening to you isn't fair. I understand that, and I'm going to fix it. And that was a message that really resonated with people. And I thought to myself, that's what happens in medicine all the time, is that what has happened to our patients isn't fair. And doctors, maybe I shouldn't put it on the doctors, the healthcare system has promised that this isn't fair to you and we will fix it. And that leads patients down these rabbit holes of expectation, application of technology, inappropriate whatever, because of this. You know, someone understands that this isn't fair. I know it's not fair. And rather than just sort of sitting down and saying, yeah, my chemistry teacher from high school I remember very little from high school, but I remember Maggie Engel, our teacher, one of the students just said, well, Mrs. Engel, this isn't fair. And she said back to him, well, of course it isn't. Whoever said it had to be. And that to me was a really interesting lesson in life that I've kind of hung on to. Yeah, it's not fair, but who said it has to be? So. Other comments, reactions, closing comments, Brad?
Are you muting yourself? I'm back on. No, thank you. I appreciate people's input and listening. And yeah, none of it's easy. But as I said, I think it's what we do, or why we do this, is to walk with families in these tough situations. You keep walking towards them. So thank you all for your time.
Thank you, Brad. We really appreciate that.